Hello, smiling made that come off. All right, it's me again. Just the last part now of our paediatric assessment, and this part is about vital signs observations and history taking before you actually start any type of assessment. So, really, really important. What we've done so far is we've done a hands-off assessment involving the paediatric triangle following our primary survey. We've already thought about the anatomical and developmental differences of children, and now we're going to be thinking about how we go about questioning to find out what's up and about what their vital signs should be. So see here on the screen, we have the page for age. You might have come across this before, you might not. This is in your JR Calc. So whether you've got JR Calc app, whether you've got the JR Calc pocketbook, whether you have got the huge JR Calc, whether you've got 2019 version, 2016 version, you will find the page for age. If it's in a book, it's at the back. Now, what this is separated for various milestones of pediatric life so that you can tell without having to do any formulas what drugs, what concentration, what volume of drugs that you should be given for the pediatric. But also on the top here, there, this bit here tells you the OBS that should be for that child. Now, this is sorry about the picture here, but I don't actually have the book home with me when I'm doing this, so I had to take this off the internet. But this shows a 3-year-old. So it goes up basically, I think it goes like 1 month, 2 months, 3 months, 6 months, 9 months, 12 months, 2 years, 3 years, 4 years, 5 years, 6 years, 7 years, 8 years, 9 years, 10 years, 11 years, 12 years, full stop. And then they're considered whether they are more like a 12-year-old or more like an adult. So up here we have the weight, which we would expect for a child of that age to be, the normal range of heart rate, the normal respiratory rate, and the normal systolic blood pressure. So you've always got an idea of what you're going to expect when you come to that child. So my advice to you is if you're on the way to a call and it says a 3-year-old male has jumped from the bunk bed and is crying in pain or whatever, then you can look up your stuff for a 3-year-old and you can say, right, his rest rate should probably be between, let's say, 25 and 29. I'm not sure off the top of my head what it should be. His heart rate maybe should be between 100 and 120, and his systolic might be 80 to 90. You get that ready on the way to the job so that you know in advance how you can compare those OBS. So what OBS do you think you would do for a pediatric patient? So again, it's activity time. You can get yourself a drink if you want, or do whatever you want, or just crack on with it. So you're going to pause me and you're just going to write down what OBS do you think is important to take for pediatric patients. Remember what I said before? I like to ask why, justify your answer, and so what, those kind of questions. So if you say, yeah, well, I always definitely want to take a temperature, I will say, well, why? Why always definitely? If you had that little kid that fell off the bunk bed, does he need his temperature taken? And then you'd have to justify it to me. Either way, if you say yes, he might have an infection that caused him to be dizzy and fall off, I'll say good on you. If you say no, he's simply fallen, I would say, are you sure? And then if it's the case, good on you. All right, so you don't have to necessarily be right or wrong. Just think about why. Okay, so time starts now. Pause me. Think about the OBS that you think it's important to take. Right, so I've popped these into ABCDs. This is the way that you might want to do it. When you get a little bit more experienced, you'll probably change these around. So, for example, if you went to a 6-year-old who was having an asthma attack, the first things you might want to do are check the rest rate and the SATs. Whereas if you went to a 5-year-old that had fainted, perhaps the first thing you want to do is check blood pressure or check blood glucose. If you went to somebody that was throwing up, vomiting, you might want to check their temperature first of all. So for now, you can learn it like this. You can take it like this out on placement. But then when you're starting to see patients and you're getting more comfortable with your assessment technique, you'll start to think to yourself, this is a potentially fluid loss because it's diarrhea and vomiting for 5 days. I'm going to go straight to pulse and blood pressure. I'm going to straight to test for dehydration. So do it whatever order you feel comfortable with now. In the second year, I will be asking you to do it in the order it's necessary. All right, so airway, as we've already discussed, that's high, high. Right, you've got an airway. Brilliant. Let's move on. Don't forget, if you come to any of these and they need corrected, don't move on. Correct them. So, for example, if someone's got a respirator of 2, you might want to get the bag valve mask on rather than going, oh, no, I must carry on and do my full assessment. Okay? Simple. All right, breathing. We're going to check for the respiratory rate, and that involves the effort and the depth. So with a pediatric patient, because their respiratory rate is so variable, it goes up and down all of the time, I want you to count this for a minute. If you're in an emergency situation, maybe not a minute. Maybe you'll cut it down to counting over 20 seconds and multiply by 3, or 30 seconds multiplied by 2, or even 15 seconds multiplied by 4. But that's quite inaccurate. So if you've got the time, I want you counting the rest rate for 1 minute. I want you doing it inconspicuously. So get the mum to talk to the patient or whatever. Do something to distract them, and you watch the rise and fall of the chest. You do not go, I'm just counting how many times you breathe in. Okay, go. That will give you a false reading. All right, the effort, that's just noting down increased work of breathing or no increased work of breathing. The depth, are they taking deep breaths or little shallow breaths? Why is that important? Well, it's to do with the exchange of gases. You'll learn about end-tidal CO2, but that can make somebody dizzy if they're taking shallow breaths, quick shallow breaths. So that's important. In the breathing as well, I'm going to check for oxygen saturation. So for any large children, like with adults, the little clippy cling goes on the finger. Infrared dot is checking the oxygen levels in the hemoglobin. Normal would be above 96%. Jerichow says 94 to 98, but I'd say above 96 is normal. For pediatric, you might have to put it on their thumb or on their big toe. If you're lucky enough to have one of those connections, it will come in the form of a plaster that you can put around any finger, any toe. And you take the SADs. If they seem to be about 80 or something like that, have a look. Look carefully. Is it fluctuating? If it's fluctuating, it's probably wrong. If it's not fluctuating, get the oxygen out. Quick! Right, so definitely taking SADs. Definitely taking respiratory rate. End-tidal CO2, not normally important for pediatrics. Not normally. That more likely comes with people in cardiac arrest afterwards. So you might use it on a pediatric if you're looking at ROSC, return of spontaneous circulation. If you're looking at intubation placement, you'd be looking at end-tidal CO2 then. For patients who are conscious, you might look at it in asthma. You might look at it in hyperventilation and panic attacks. That's not normally common in pediatrics. So I wouldn't say you necessarily have to look for the end-tidal CO2. Peak flow. You guys know peak flow is really important in asthma. However, if somebody can't do a peak flow, then it's completely irrelevant. So if you have a pediatric patient who's having an asthma attack and they know how to hold the flow meter, how to take their breath, how to position the lips, how to do that one sharp blow, then great. Give them it. There you go, best of 3. Check it up against their normal. If they don't know, you're wasting your time and you're getting them to do something that's going to make them more out of breath, more distressed. So you need to weigh that up, whether you need to do peak flow or not. All right, so moving on to circulation. Pulse rate, definitely. Remember where we tested it? So on little ones, we're looking at the brachial. On the bigger ones, we're probably looking more at the radial. Cardiac arrest, we're looking at the carotid. as usual. So we didn't want to know how fast it's going. What is its beat? What is that compared to the normal range of heart rate? Is it within range? Is it higher? Is it lower? I.e. tachy, brady. Not only are you checking what the rate is, when you're feeling the pulse, I want you to feel, is that regular or irregular? Most of the time it's going to be regular. If it's irregular, I want you to say, right, okay, so does it become irregular every nth beat? So for example, every fifth beat, it drops, drop a beat. Sorry. If it's completely all over the place, it's irregularly irregular. If you feel something irregular, say, is there any cardiac history? Don't worry the parents, it just might already be there. Yeah, figure out where you can feel it as well. So if you can only feel it here, fine. See if you can feel it also in the carotid. See if you can feel it in the brachial. Note that down. I said bakery. God, it's Christmas. It's made me hungry. Okay, blood pressure. We've discussed that earlier on. I think it's necessary if there is any type of question over the circulating volume in the patient. And I said the cases where you might look at blood pressure would be dehydration, and that would mean diarrhea, vomiting, urine retention. If there is potential for blood loss, either externally or internally, so that would be trauma, depends on the mechanism of trauma, and in burns as well. If you're thinking there might be fluid loss through the plasma, it's definitely worthwhile doing blood pressure. Outside of that, I mean, it's not always accurate, but if you've got a patient that lets you do it, then why not? All right. Cap refill. Now, there's questions as to how relevant this is, how accurate this is, but I would say yes, do a cap refill. So we do a cap refill by pinching the end of the finger, hold on for 5 seconds, then you let go. How long does it take for the finger to return from white to pink? Now in pediatrics, it's still 2 seconds. So you should expect to see that turn back to pink in less than 2 seconds. If it's prolonged, that's a red flag. That can be circulatory problems. So that needs attention if you find a prolonged cap refill. ECG. Now, we don't routinely do ECGs on patients, pediatric patients, I should say, sorry. If they've got a cardiac condition, you can question whether you need to do it or not, whether you think it's some type of symptom of cardiac condition, then yeah, by all means do an ECG. If you're not sure whether to do one or not, then it's probably best to err on the side of caution unless it's going to cause distress. But what you could do, sorry for that wobbling the laptop, what you could do is a 3-lead, which actually involves 4 of the leads, the limb leads, so the red, yellow, right, your green, black. Put them on the 4 limbs, and then you can at least get a rhythm strip, and that can tell you whether it's regular or irregular. So if you feel the pulse being irregular, definitely it's worthwhile doing a rhythm strip. Now, the one time that I would say it's vital to do an ECG is if the patient has an unexplained collapse. So, for example, out playing sports, they just fall down. They're only out for like seconds. They get back up again. They're absolutely fine. Don't want to go to hospital. Hello. No. You need to double check that that is not a heart problem that has caused them to collapse. Anyone that wants to look into it further, it's called Wolff-Parkinson-White. And you'll hear a little bit more about that in Richard's course in 2nd year. But that's a lifesaver if you can detect Wolff-Parkinson-White with somebody who has an unexplained loss of consciousness. All right, but generally we don't tend to do ECGs on pediatrics. Moving on to disability, we've discussed AVPU and GCS. Always do that no matter what. If you can't do GCS because they're not talking to you and you think they're deliberately not talking to you rather than mental not talking to you, then write that down. Could not complete GCS due to patient not willing to speak. But you can say whether they're alert or not. Okay, pupils. I want you looking at the pupils of Any child that might be subjected to alcohol, drugs, poison, bleach, any type of ingestion, I want you looking at pupils. If there's a head injury, concussion, unexplained vomiting, unexplained loss of consciousness, I want you looking at pupils. So what we're doing is we're shining the pen torch in, and we're seeing if they react to light, if they're reacting around to the accommodation, if they dilate, if they constrict. So we're also looking at what size the pupils are too. So we note that down. Check from one side to the next. Compare. Are they the same? Are they reacting the same? Are they round? Are the pupils round, or are they funny shaped? Is there anything strange about the eyes? Note that down. It's very important. If you just have a patient who, say, twisted his ankle at football, you might not want to do pupils. You might not feel it's necessary. Depends if it's going to annoy them or not, I would say. All right, blood glucose, again, a debatable one. For me, my advice to you is any pediatric that is sick, like unwell, you think, I don't know what's wrong with them, or I think it's probably this, but I'm not 100% sure, do a blood glucose. Right? If you've got the kid that twisted his ankle at football, might not need to do a blood glucose, but anyone who's strangely unwell, definitely do one. What's a normal blood glucose reading? Is it the same for an adult? Yeah, it is. So it should be between 4 and 7. If the pediatric has got diabetes, you definitely want to be doing it. If you see a blood glucose that's low, you'll be thinking, why is it low? Is it undetected diabetes? Are there safeguarding issues? Has this patient eaten? If it's remarkably high, you'll be thinking, why is it high? What kind of food are they eating? Is there a safeguarding issue? Infection will make the blood glucose rise. Cardiac problems can make a blood glucose rise. So if it's high, you can at least note that and hand it over. They can do further investigations as to why, but you have noticed it. Temperature, most of the time, yeah. Most of the time I'm doing a temperature. Even the kid that's twisted his ankle. Well, I mean, you'd be forgiven if you didn't do it, but full set of obs, why not? So know your normal temperatures. What's abnormal for children depends on the sepsis score, depends on the news score, the early warning score. Normally it's 38.3 for the over ones, and then I think it changes for under ones, but you need to check that up. I couldn't tell you completely 100% confidently. I can tell you what I think it is, but I won't. All right, let's move on to E. All right, E is exposed. As you know, if at this stage you haven't looked at the patient's body, it's time to look at it. So we need to have the patient naked. Pants are okay, but when we're looking for rashes, sometimes rashes start in peculiar places where we wouldn't tend to look. So that's the top of the legs, under the buttocks, in the little creases of the groin, in the armpits. So sometimes if you're having a glance at a patient, you might miss a rash. And if that's meningitis, then shame on you. So make sure you check all over for rash. Make sure that there is somebody else present as well. You know, you do need a chaperone for this. And check all over for rash. If you think it's a heat rash, ask the caregiver, you know, have they had this before? Ask about family history. Has anyone else got a rash? Ask what they've eaten. Ask if it's a new detergent. You need to figure out what kind of rash this is. Like I said to you earlier on, we're mainly concerned about the meningitis rash. So at this stage, if you're exposed, you've seen little purple dots rash, think meningitis. We're going to talk in a minute about different signs and symptoms of meningitis, but with the rash, you need to do the glass test. So with that, you need to roll a glass over it and see whether the spots, the rash itself, disappear or if they stay. Right, and if they stay, that's meningitis. Well, it's query meningitis. Okay, other rashes, you do need to find out what they are, where they are, and whether there's any other symptoms associated with them, such as itchiness, unwell, lethargic, anything like that. Any deformities, and that would be from trauma, accidents, those kind of things, swelling, breaking, scars, cuts, bruises, etc. Check for the medical history, because there might be some scars because they've been in hospital with a broken bone or an operation. Don't just assume. Anything that can't be explained, maybe need to ask a few more questions. In the back of your mind, be thinking about non-accidental injury. Now, this is quite a horrible thing to think about, but you need to be aware of the signs that are there that might show up as inconsistent with the story. So, different bruises will tell you different stories. So, like, we've all um, fallen over, bumped ourselves, etc. as children. Those kind of scrapes and bruises tend to occur around the hands, knees, elbows, those kind of places. If you're seeing bruises in a strange area like the back, for example, ask how they got it. That might be suspicious. Different stages of recovery of bruises. So if you've got some that are purple, some that are brown, some that are yellow, this kid's having a lot of issues. So they've got a lot of recovery of bruises. That's suspicious. Look at where the injuries are. So, for example, the classic burns on feet. That can be punishment, dipping the child in scalding hot water, for example. You might be looking at their body language, etc. as well. If they're talking to you normally, or if they seem to be a little bit shy or wary of adults, that can be a sign. I'm not saying phone the police. I'm saying note your concerns, discuss it with your crewmate, and then you might need to do a safeguarding or a welfare referral, and you might need to pass it on at hospital as well. As I said earlier on, you will have a separate session all about safeguarding. This is just a tiny little dip into that for now. All right, the next thing I want you to be thinking about when you expose is dehydration. We've already talked about dehydration in terms of blood pressure. There are other signs for dehydration. So we're thinking about, first of all, the history, urinary signs, symptoms, urinary history. We're thinking about how the skin looks, how the mouth is, do they seem dry? We're thinking about the story that leads up to it. Is there any way that could be a fluid imbalance, some type of loss of fluid that would cause a dehydration? But in terms of our vital signs, we're probably looking at blood pressure, and we're looking at turgor of the skin, which I'll explain shortly. Lastly, in our vital signs, we're thinking about the environment that the patient's in. So again, as you did with the end-of-bed assessment, looking around the room, seeing if there's anything that causes you concern, or seeing if there's any clues that might explain the reason for the patient's illness. Again, in the back of your mind, thinking about safeguarding. Excuse me. Right, next slide, please. Okay, nextly, we're going to come to history taking. Now, when you're out on the road, you will see that your mentors do vital signs and history taking at the same time. This is something that you don't have to do just yet. People do that when they're quite experienced. For now, you need to concentrate. So, depending on what's up with the patient, you can get a short history first and then do the vital signs, or you can take a full history and the vital signs, or you can try and get a bit of a history while taking the vital signs, but you need to pay attention. So, if you can't do both at the same time, don't. Short history would be, okay, so tell me what happened and what were they doing when that happened. Right, let's do some ops. Full history, as you know, is a structured approach. So you have your mnemonics, which I've written there, all highlighted for you. They will tell you how to do a proper history. So whether you use sample, which is signs and symptoms, allergies, medication, past medical history, last oral intake, events leading up to the illness, whether you do OPQRST, so that is a pain assessment, so that's onset of pain, what provokes pain, the quality of pain, does it radiate anywhere, severity of pain, and the timing of it, does it come and go or does it stay the whole time. You might use the medical model, which when you come to me in second year, I will try and press you to use this. This is you writing about the presenting complaint, the history of presenting complaint, what you find on examination, the past medical history, the drug history, the social history, the family history, and then a review of systems, which is basically check the cardiovascular system, check the neurological system, check the respiratory system, check the digestive system, check the reproductive sexual history system, maybe not for pediatric, check the gastrointestinal, check the urinary. Okay, or Socrates. Socrates, again, is another pain assessment tool, and that is the site of pain, the onset of pain, character of pain, does it radiate, is there any associated symptoms, the timing, any exacerbation of symptoms, and the severity. Okay, so you need to do your usual history taking with the pediatric. Don't forget that. This is not an excuse to skip that out. That is going to tell you loads of information, whichever one you use. In addition to that, these bits and bobs that I've put down there are what's extra. You need to know these. You need to ask the patient these in pediatric assessment. So first of all, dehydration. I'm suffering currently, but I've run out of juice, water. So the signs that you might see, we talked about blood pressure. So dry tongue and lips, you might notice that it's white or cracked all around the mouth area. You'll hear it, and they will say, I feel thirsty all the time. Big clues. Dry nappies. So when you're looking at pediatrics and babies that are in nappy wearing age, you ask, when was the last time that the nappy was wet? So parents know this. Parents know this stuff. They can tell you, yeah, it was 2 hours, 20 minutes ago. Nah, I don't know how they know. But if you have had a dry nappy, not you, if the patient has had a dry nappy for over 3 hours, I'd be a little bit alarmed. If you're looking at over 12 hours, that's really serious. That's urinary retention. And that's going to cause a lot of problems. So find out when's the last time they had a wet nappy. Dry crying. This is a thing. When pediatrics are very dehydrated, they will be crying through pain or whatever else, and there's no tears coming out because the glands are not producing the tears. It's not drama. It's not pretending to cry. It's not a wee tantrum. It is dry crying, a sign of dehydration. Look out for it. Fluid loss, that comes in the history. We've talked about that already. Urinary symptoms. What do I mean by that? So I mean needing to go to the toilet a lot, like every half hour or so. When you go to the toilet, either there's loads or you feel like there's loads, but there's only a little dribble. Pain when urinating, passing urine. Any type of blood in the urine, any type of strong colour. So urine's normally a bit of a yellow colour. So when it turns brown, it's strong. You might have a retention with that. When it's pinky, then that could be that there's some blood in it. And smells. So strong urinary smell. I mean, you'll know the smell. I don't want to tell you it smells like fish. I don't want to put you off, but it stinks. Anyway, you will detect that because it's something you don't forget, that urinary smell. So ask them about urinary symptoms. Ask the parent about the urinary symptoms. Next, oh sorry, I forgot, dehydration with little small babies, the fontanelle in their head can become depressed. Now that changes, that grows after about 3 or 4 months, so you'll only see it on tiny babies, sunken fontanelle. Next is immunization history. This is really important. You might have been on placement or you might have known about the Red Book. So the Red Book is literally just like an A5 size book, and in it says the patient's name, date of birth, where they were born, etc. And they have their immunization history in there. So every time they get the jabs they're supposed to, they get a little stamp. Their weight is recorded, their development is recorded in this red book as well. So when you go to a pediatric, especially a small one of the first things you say to the parents is, "Oh, can I see the red book?" That will tell you a lot of information. So you can ask the parent, or you can look it up in the red book. Is this patient up to date with all their immunizations? And this question is vital. We need to know that. We need to know if they're at risk of any of the illnesses, such as like measles, mumps, rubella, those kind of things. If they haven't had the injections, why not? Now, you're not trying to start a war. You're not trying to start a debate about whether the MMR jab causes somebody to be on the autism spectrum. You are not asking for that. You're just trying to find out, is the patient being deprived of their immunizations, or were they just unable to attend the appointment for whatever reason? So find out why they're not up to date with their immunizations if that's the case. I've put a little link in here. So when you can, go to don'tforgetthebubbles.com, and there is an immunization schedule here. I'd advise you to print that out so that you know when kids should be having their injections. So if someone says to you, yeah, they had their MMR at 4 months, that's it, isn't it? That's the only one they need, isn't it? Then you can look up your schedule and say, actually, they should have had one on 3 months and they might have one on 6 months. I've made that up. I don't know what it is without checking the immunization schedule. So have we looked at that? Actually, while you're there, that's quite an interesting site. Don't forget the bubbles. And it's something you can follow on Twitter as well. It tells you a lot about pediatric illnesses. I'm really interested in them. I don't know why anyone's not interested in them, because we can save little lives. We can detect it when everyone else is feeling a little bit scared, maybe, about pediatrics. Anyway, let's get back to the zone. All right, the birth history. So obviously, you're not asking this to the pediatric. They will remember. So you can ask it to the caregiver, the parent. So was it a normal birth? Normal birth means per vagina. So that means a normal delivery, lasting whether it lasted 2 hours or whether it lasted 20 hours. That's a normal delivery. Get forceps involved, that's not necessarily a normal delivery. So the baby might have become distressed. Having cord round the neck, that's not a normal delivery. Coming out feet first, shoulder first, not a normal delivery. Cesarean section, not a normal delivery. So we ask the parent, was it a normal delivery? We also ask about any complications. So that might be things like gestational diabetes. That might be things like eclampsia, preeclampsia, which is high blood pressure during pregnancy. There might be hemorrhage. There might have been multiple births. There might have been multiple miscarriages before birth. Anything that's an obstetric history is going to be relevant here. So we ask for any complications with baby or with mum during and immediately after pregnancy. Now here it might include postnatal depression. So if the patient discloses that to you, that's still important. Write it down. You don't have to ask them any more about it. Just hand it over when you're taking the patient in. So growth and development, again with this, you should be able to find out that information from either the parent or caregiver or the Red Book. Find out if they're up to date with what they should be doing. For example, crawling, talking, walking, whether their height and weight are normal, especially if they were premature. That would be another birth complication. If they were premature, they might be underweight, etc. Really important. Okay, lastly, family history. So you need to know how many people are living in the house with the pediatric. Have any of them got any medical issues? It might be hereditary, it might be genetic diseases. Whether there's any significant history of illness, accidents are to be thought about in terms of safeguarding. But if you've got one sibling that has particularly had a lot of broken bones and no other siblings have, it might be just down to time and place. Whereas if a lot of the siblings are turning up with unexplained injuries, that can raise your guard you would be suspicious that you might need to do safeguarding referral. Right, so you've got a lot to take in there when it comes to pediatric specific history taking on top of your usual history taking. So you might need to jot these down before you go on placement. If not, I do know that first year is more observational and getting the hang of it. We will go over this again in Advanced Patient Assessment, OMED 1401, in second year. So if it seems loads of information, taking as much as you can, pediatric triangle. Oh, actually, let me put the summary on and we'll talk further about that. All right, so when you approach a pediatric patient, think about their big head, think about their blood volume, think about their tiny little organs, think about their short airway, think about all of the anatomical and physiological differences and how that's going to affect you and your treatment of them. Understand how you can assess them from across the room or from first impressions. With that, use your pediatric triangle. Remember always the three sides of the pediatric triangle. Appearance, that's tone, interaction, consolability, look / gaze, speech / cry, work of breathing, and circulation to skin. Remember your pediatric triangle. Think about the vital signs, know where you find them on your JR Calc. Make sure you're familiar with that. All right, you don't want to be turning up to a cardiac arrest going, where did she say it was again? Just look now, get your JR Calc, look now, and find where you can find what an 8-year-old's rest rate might be. Know roughly what it's going to be so that if it comes through to you as 50, you go, whoa, that's way out of control, without even having to look at the book. But of course, you're going to check it up as well. And expand on your usual history taking. Right, there's plenty to do there. Now, did I not put in about rash? No, I didn't. All right, I'm going to put a separate little case study up about rashes. I'll get Scott to log that onto the portal as well. Anyone that wants to ask me any questions, here are my details. If you're on Twitter, you might already be following me. If you're not, I do tweet about pediatric stuff. I tweet about a load of stuff. Sometimes it's not even relevant. Sometimes it's about like Serena Williams or pizzas or my dog or whatever. But I do a lot of medical stuff. So follow me, follow Scott. You'll find loads of the rest of us on Twitter as well. Question and answers usually go on to the module forum for OMED 1398. However, if it's specifically to me, I would suggest you email me. So I've popped the email address up there as well. If it's something that goes on the forum, Scott will either answer it or tell me when I'll answer it. Any further reading you might want to do, I've written a few references here. I like don'tforgetthebubbles.com. You can find a load of resources in there. If you're listening to podcasts, I would recommend 2 Peas in a Pod. And I also like this here, Mind Gap. So this is to show you that illnesses, rashes, cyanosis, etc. don't always happen on white skin. So most of our textbooks just show us little white pediatrics with rashes that we can all see. We need to remember about brown and black skin. So this is an excellent resource made by a student from St. George's, and it's something that I want you guys to look at whenever you can do. All right, hopefully this has been enjoyable, and I shall see you in the not too distant future. Thank you for listening. Bye.